Bismillah ar-Rahman ar-Rahim. Drugs used in management of pulmonary hypertension. The drug used in management of pulmonary hypertension include the following. First, the calcium channel blockers. Vasoresponders at right heart cath should be considered for therapy with calcium channel blockers. They should not be used in those with a negative vasodilator challenge, as they may increase the mortality. Only a small number of patients with idiopathic pulmonary arterial hypertension and vasodilator response at right heart cath do well with calcium channel blockers. Now classified as 1.5. High dose nifedipine 120 to 240 milligram daily and diltiazem 240 to 720 mg daily are recommended in patients with idiopathic pulmonary arterial hypertension with a positive vasodilator response. They should then be followed closely to determine if they are long-term calcium channel blocker responders with repeat right heart cath after 3 to 4 months of treatment. If their response is inadequate, further pulmonary arterial hypertension therapy should be started. Vasodilator responsiveness does not predict a favorable long-term response to calcium channel blocker therapy in patients with arterial pulmonary. Again, vasodilator responsiveness does not predict a favorable long-term responses to calcium channel blocker therapy in patients with APAH type, which stands for associated or pulmonary hypertension occurring in some associated conditions or associated condition with pulmonary artery hypertension and the connective tissue disease. That's to say, high dose calcium channel blockers are often not well tolerated in these patients. Amlodipine has more selective vasodilating properties and at doses of up to 20 milligram daily may be useful in those intolerant of the other agents or if right ventricle function is impaired. Calcium antagonists should be started in hospital and titrated with careful monitoring. Verapamil is not used because of its negative inotropic effects. Side effects include hypotension and edema, which may limit its use. Phosphodiesterase type 5 inhibitors, for example, sildenafil and tadalafil, this augment the vasodilatory effects of nitric oxide, causing pulmonary vasodilatation and improve exercise capacity and the hemodynamics in pulmonary arterial hypertension with in patients with functional class 2 and 3. Common side effects headache, flushing, epistaxis, nasal congestion may present. Sildenafil is taken orally 3 times a day and has proven benefit in idiopathic pulmonary arterial hypertension and APAH, which stands for Associated with Pulmonary Arterial Hypertension, associated condition with pulmonary arterial hypertension, with connective tissue disease, congenital heart diseases, and chronic thromboembolic pulmonary hypertension. Tadalafil given orally once a day. Ryoxyguat, it enhances cyclic GMP production and can be used in inoperable chronic thromboembolic pulmonary hypertension, pulmonary idiopathic pulmonary arterial hypertension, and pulmonary arterial hypertension related to connective tissue disease. Results are favorable in terms of exercise capacity, hemodynamics, and disease progression. The prostanoids. Prostacyclin is produced predominantly by endothelial cells and is a potent vasodilator. It inhibits platelet aggregation and has antiproliferative and cytoprotective properties. Side effects are usually dose related and include headache, jaw pain, diarrhea, flushing, nausea, arthralgia. The prostaglandin treatment doubles the time on the lung transplantation waiting list and improves transplantation outcomes. Again, prostaglandin treatment doubles the time on the lung transplantation waiting list and improves transplantation outcomes. Improved hemodynamics may lead to some patients coming off transplant waiting lists. Tolerance develops to IV prostaglandin therapy with increasing dose requirements over time. The mechanism for this is unclear. Ibuprostenol, a synthetic prostacyclin analog potent vasodilator acting via increasing intracellular cyclic adenosine monophosphate CAMV, it is the only drug shown to improve survival in idiopathic pulmonary arterial hypertension in randomized controlled trials. It is probably has its effects as selective pulmonary vasodilator and potentially through vascular remodeling and platelet adhesion. It also improves symptoms, exercise capacity, and hemodynamics in idiopathic pulmonary arterial hypertension and pulmonary arterial hypertension associated with scleroderma. It is inactive in the circulation after 5 minutes and is given therefore by continuous IV infusion via a portable pump and a tunneled central venous catheter. Pump failure can be life-threatening. Triboprostenil is a prostacyclin analog that can be given as a continuous subcutaneous or IV infusion as it has greater in vivo stability than ibuprostenol. It improves symptoms, exercise capacity, and pulmonary hemodynamics. Pain at the subcutaneous infusion site is the major side effect due to its current pricing structure. Treprostinil is not routinely prescribed for, for new patients. Iloprost is a prostacyclin analog and is more potent than ibuprostenol. It has a half-life of 25 minutes and can be given by continuous IV infusion or nebulizer 6 to 9 times a day. Side effects headache, cough, and mild diarrhea and nausea can occur. Selexibag, an oral prostacyclin IP receptor agonist, shown to reduce the composite of death and disease progression on its own or when used in combination therapy. Endothelin, endothelin receptor antagonist, ERA. Endothelin is a powerful vasoconstrictor and pro-inflammatory mediator and causes smooth muscle cell proliferation. Plasma levels raised in some forms of pulmonary hypertension. Bosentan is an oral endothelin receptor A and B antagonist shown to improve exercise capacity hemodynamics, functional class, and time to clinical worsening in patients with idiopathic pulmonary arterial hypertension and APAH with connective tissue disease and is a Menger syndrome. The first oral therapy approved for the treatment of pulmonary hypertension, 3-year survival for cohort of mainly WHO functional class 3 patients starting on bosentan with more than 85%. The major side effect is reversible liver transaminitis, causing discontinuation in approximately 3%. Liver function tests should be monitored monthly during the treatment. Other side effects include headache and peripheral edema. Ampresentan is a selective type A blocker with a better life safety profile, can improve symptoms, exercise capacity, hemodynamics, and time to clinical worsening in patients with idiopathic pulmonary arterial hypertension or associated pulmonary artery hypertension, idiopathic pulmonary arterial hypertension, or and associated pulmonary arterial hypertension with HIV and connective tissue disease. Mosentan is a dual endothelin receptor antagonist shown to reduce a composite endpoint of morbidity and mortality and increase exercise capacity. The current practice, there are very clear nationality there are very clear nationally agreed guidelines on starting treatment of pulmonary hypertension. Drug therapies for pulmonary hypertension should only be commenced by by designated specialist pulmonary hypertension center. Non-specialist clinics, non-specialist clinicians should not routinely prescribe these therapies. These centers use calcium channel blockers in vasodilator responders, but only continue this if there is a sustained response. Otherwise, first line therapy, dual therapy is started much sooner than previously recommended and may be started first line in select patients. Usually, PDE inhibitor is started followed by quickly adding an ERA to optimize patients. Triple therapy only of patients for patients who have been accepted as suitable for transplant. Pulmonary hypertension management 2, which include general and surgical management. The general management include the following: anticoagulation. All patients with CTPH or chronic thromboembolic pulmonary hypertension, the most with idiopathic pulmonary arterial hypertension, should be commenced on anticoagulation. There is no evidence for use in other subtypes unless otherwise indicated. Long-term O2 hypoxemia is due to reduced cardiac output, VQ mismatching, and right-to-left shunting through a patent foramen ovale. Added oxygen therapy may reduce any further rise in pulmonary artery pressure resulting from additional hypoxic pulmonary vasoconstriction. Supplemental O2 should achieve PO2 more than 8 kPa during rest, exercise, and sleep. Diuretics and digoxin. The diuretics may be useful for the treatment of edema, but excess preload reduction may limit their usefulness. Digoxin has been shown to improve cardiac output acutely in idiopathic pulmonary arterial hypertension. Though its longer term effects are not known, treatment of arrhythmias is very important in management of pulmonary hypertension. Identification and treatment of iron deficiency anemia, because iron deficiency anemia is common in pulmonary artery hypertension and may be associated with worse outcomes. Look for an underlying cause and consider IV iron replacement, as oral iron absorption may be poor. Immunization, annual influenza and one-off pneumococcal vaccination. Contraception may be required as pregnancy is poorly tolerated in idiopathic pulmonary arterial hypertension with a 30 to 50% mortality. The surgical management in pulmonary hypertension, pulmonary thromboendarterectomy is the treatment of a choice in chronic thromboembolic pulmonary hypertension for proximal obstructive disease. This is the surgical removal of organized thrombotic material and aims to strip away the pulmonary arterial endothelium, starting proximally and extending out to remove all clots in the subsegmental levels. It's done on cardiopulmonary bypass with circulatory arrest. The pulmonary arterial pressure usually falls within 48 hours of surgery. Operative mortality is below 110 in experienced hands. Atrial septostomy, creation of right to left shunt by a balloon. Atrial septostomy aims to increase systemic blood flow by bypassing the pulmonary circulation, particularly in patients with syncope or severe right heart failure. It is a palliative procedure and can be used for symptom control prior to transplantation, with the defect being closed at the time of transplant. Also used in people receiving prostanoid therapy having syncope. Arterial desaturation occurs following the procedures but is not but is normally offset by the increased cardiac output seen with increased O2 delivery. It is not indicated in severe left heart failure or in patients with impaired left ventricle function. Balloon pulmonary angioplasty is a relatively new procedure for distal chronic thromboembolic pulmonary hypertension with Webb disease. This is usually this usually requires multiple catheter lab treatment and is only performed at the Royal Papworth Hospital in the United Kingdom. Transplantation improves survival and the quality of life in patients with pulmonary hypertension. In those with preserved left ventricle function, lung transplant is the procedure of a choice. Return of normal right ventricle function is found after transplantation. As for all disease needing transplantation, timing of referral and operation is crucial as organ availability is limited. The incidence of obliterative bronchiolitis appears to be higher post transplantation for pulmonary hypertension than in transplantation for other diseases, although the reason of, for this is uncertain. Prognosis. Prognosis of pulmonary hypertension is variable depending on a functional class, hemodynamic compromise with cardiac index, right atrial pressure, and the prognosis is linked to mean pulmonary artery pressure at presentation. The clinical course is one of progressive deterioration with episodes of acute decompensation. The median survival in New York Heart Association Functional Class 3 symptomatic or mild exertion is 2.8 year and 6 months in New York Heart Association Class 4 symptomatic at rest without treatment. End of life care Palliative care by multidisciplinary team (MDT) may be warranted to improve symptoms such as fatigue, restlessness, abdominal bloating, nausea, and pain. Further developments for pulmonary hypertension management. A number of agents are currently being investigated, including RHO kinase inhibitors, vascular endothelial, vascular endothelial growth factor receptor inhibitors, and angiopoietin 1 inhibitors and elastase inhibitors. Animal studies have suggested a possible role for gene and stem cell therapies. That's all, thanks.